epilepsy. And that is the most important aspect, and not to overdiagnose epilepsy, which has got a lot of misconceptions here. I think without wasting time, we'll go on to the next lecture, which is on fits, feints, and funny turns, masking the diagnosis, by none other than Professor Christopher Mathias, who was here with us about 2 years ago as the TVS orator of 2015. And Christopher Mathias is here now to talk to us about this important aspect. Can we have the slide? Introduction slide is there. A very well-known neuroscientist, and he is from India, and he is now settled in UK. He is a citizen of UK now, and he has worked extensively on autonomic nervous system, and he has written a book on autonomic nervous system, which has been read by each and every one of us in the field of neurology. And it is wonderful to have him here and to talk to us about the fits, feints, and syncope, because this is the major area where epilepsy is mistaken. As in this country, now the demography has changed. The people, they are all living longer. The common age is now about 65 to 70 years. And when the age increases, there are many disorders which can mimic like epilepsy, as Professor Bakovic has pointed out. And that's why this is an important area, and he is giving a talk on this. He has been emeritus professor at University of College of London since 2014, and is an honorary consultant physician at St. Mary's Hospital since 1982. Christopher Mathias, please.
Well, Professor Satish Chandra, various eminent colleagues, ladies and gentlemen, it's a great pleasure to be here back again. Always a pleasure coming and visiting Krish and the faculty here. And particularly on this occasion, in fact, to listen to talks, I'm in a way sandwiched between two very eminent speakers, which you know, of course, very well, but importantly, they're experts in epilepsy, and as you probably gathered by now, I'm the odd person out, as it were. So I hope you will bear with this, but in a way it's of some relevance, and Krish has got to be thanked for, in fact, suggesting both the title and the fact that there can be considerable overlap. And I think Professor Berkovich has already stated one of the problems. In fact, my most grateful patients, especially young ones, are the ones whom I tell do not have epilepsy, obviously in consultation with my epilepsy colleagues, and say they've got an autonomic disorder, which usually, not always, is slightly more benign, as it were. So what I'm going to do, in fact, and this is just a few introduction slides, as it were, and then give you some examples, as it were. Now, none of you in the audience, I'm sure, need any reminding that the autonomic nervous system is a very simple system. As you can see from this, it's not entirely an efferent system. You've got the sympathetic going to every organ in the body, and you've got the two components of the parasympathetic also innervating every organ in the body. There is a fairly marked central component also, and this gives, of course, scope to a number of areas where things can go wrong, in the brain, in the spinal cord, in the peripheral nerves, and also at the neuroeffector junction. So a number of aspects to this. I'm going to concentrate on the cardiovascular problems which occur, and those which are particularly relevant to seizures and epilepsy in a way, although it'll be very much an autonomic talk, as it were. Now, the patients, I'm just going to broaden this a bit. It's not just fits, feints, funny turns, and I hope you don't mind, in fact. I'm going to be using a number of terms which patients are referred to, which start with an F word. So there are no children here, I hope, as it were. They're not four-letter words, by the way, all of them. So they can come with feints, near feints, pre-syncope, funny turns, falls, and of course fits. Usually that last category are the most infrequent in terms of direct referral to me. And in terms of actually on the autonomic side, it's dizziness, pre-syncope, and syncope that we really need to concentrate on. There are a number of causes of these, of course, vestibular, cardiac, and so on. So we're going to be focusing on the autonomic causes. And just to very broadly divide them, they can be either fixed, which means that there's damage to the nervous system, resulting in autonomic failure. Sadly, as a result, many of these are not reversible, although in more recent years, in the last decade or two, there have been far more advances, particularly on the immune side, in terms of recognition, which is reversible. What is of importance are, in the last few decades, the recognition of intermittent disorders. So these are people who are as fit as you and I, if not better. Sorry, I shouldn't bring myself into this, but have got an abnormality which results either in autonomic mediated syncope or the new millennium disorder, the Postural Tachycardia Syndrome. Now, just a few very, very broad, simple slides. Of course, it's very important that the circulation is maintained in people, particularly while upright. And as you know, blood pressure is maintained so remarkably well because of the heart, the volume, the blood vessels. But of course, the most important part is the autonomic nervous system working on a beat-by-beat basis. So it's exquisitely sensitive. And very simply over here, these are the afferents, which convey the information into the brain. And those are the efferents, the parasympathetic, the vagus, the predominant controller of heart rate, and then the sympathetic going both to the heart and to blood vessels. And the sympathetic, of course, work predominantly, not entirely, and exclusively by the release of noradrenaline and its vasoconstriction. Now, of course, it's very important that it is objective, so it's not an eminence-based aspect of neurology. It's got to be evidence-based, and therefore you need autonomic laboratories, and this is where, over the decades, technological advances have been actually the crucial component in recognizing especially the intermittent disorders. This is one of our newer laboratories. Sorry, it's been updated in the last 6 months, in a way just indicating that it's important to have all the right equipment so that you can measure autonomic variables continuously, reproducibly, and non-invasively. And I think I might have missed a slide over here. Yes, that's lost. And you need tilt tables and all, of course, the associated aspects, including a very good team to support you, particularly when you're lecturing abroad. Or even in the country for that matter. Now, to give you a few examples on fixed autonomic disorders. Now, with this, one of the key aspects which we see is what's known as you well know, orthostatic hypotension, which is defined as a fall in blood pressure of 20 or 10, systolic or diastolic, when one is upright. And the top slide shows the response when one is at 60 degrees of head-up tilt. That's a normal subject. By the way, these are machines. In the past, we used to use intraarterial lines. That's when I started my research. I won't tell you how many decades ago. But now, because of the advances, you put a finger cuff and you get a continuous output of blood pressure and, of course, heart rate and various autonomic variables. So very little change in a normal subject. That's the typical response that you get in somebody who's got autonomic failure. The sympathetic nerves are not working, the blood pressure drops, remains low. On reversal, it goes back to its original state or even higher. In this particular patient, the vagus was also involved, so there's hardly any change in heart rate, which you would expect as the blood pressure falls. So that's typical orthostatic hypotension. Now, I put this slide up just to remind ourselves that some people get misled, depending on the history and the situations. It's not just being upright which can cause the problem, and certain aspects can enhance and exacerbate orthostatic hypotension considerably. And these include food, depending upon the type of food and how much splanchnic vasodilatation is involved, alcohol, exertion, clearly not just body temperature, but ambient temperature, and of course, various medications, which can be an iatrogenic cause, some which are needed, such as those for the treatment of PD, some which might be slightly more contentious for various other reasons, but again are essential to the individual. Now, we're talking about measurement, and you're going to say, how does this actually matter to the patient? Because that's the most important thing. And so what are the sort of symptoms that you've got to be considering? The first is that these symptoms occur predominantly when they're upright. So that's the first. And these are because you're not getting enough blood to the brain, as a rule, and other organs, enough oxygen, nutrients. So because of cerebral hyperperfusion, you can get dizziness, visual disturbances, syncope, and of course something we've recognized over the years, less obvious but subtle but clearly recordable cognitive deficits. So this is something to keep in mind in patients where people are not sure what's going on from the history. There's something known as coat hanger pain. These are muscles in the suboccipital and the shoulder region, which are ischemic. Many of these patients pass very little urine in the day because their blood pressure is low, and much more at night. And quite often they're thought to have a prostatic problem and given drugs for that, and they tend to get worse, if anything. What's been very important are the non-specific features. So some people can be weak, lethargic, fatigued, all sorts of descriptions, particularly when they're upright. And of course, more important, and I take a particular interest these days in what I call, depending on how you define the elderly, that's where falls can be a big problem, particularly in those who are more prone to having trauma from them. And this is one example, in fact. This is a patient who was languishing, might be probably a mild word, in one of the wards, and she was being investigated for everything from epilepsy to X, Y, and Z, as it were. But nobody took her blood pressure lying and standing, which is when the penny dropped in no major way. And she was, in fact, very lucky that she didn't have more traumatic damage. She almost lost the sight of her right eye, and she could have had a bleed. So these are the things which can be easily recognized even at a clinical situation without laboratory techniques, by measuring the blood pressure lying and standing, as in this particular patient. Just to give you some examples of autonomic failure, which is largely fixed, can be acute, fairly rare, can be chronic, a rare condition relatively, pure autonomic failure. Parkinson's disease, people think of the motor aspects, but the non-motor aspects are rather important. MSA, which is the typical classical PD plus autonomic failure and other components. And of course, recently, and this I realized a few years ago when I had a patient who I thought had pure autonomic failure. He was a heavyweight champion, and he started slowly dementing, and he had mild Parkinsonian features, and I thought he had dementia pugilistica, until the penny slowly dropped that he had something more than that. And we described this in 2000, I think, in fact, at the start of this millennium, with the help of one of my colleagues, Professor Martin Rosser, who's an expert in dementia. And now this is becoming increasingly recognized. And I put this here, by the way, it's not quite known as the Robin Williams syndrome, but I just put this here as an aid memoir to me, as it were, because you will undoubtedly know of Robin Williams, who committed suicide. They didn't know what he had, and in due course at PM, it turned out that he had diffuse Lewy body disease. I prefer diffuse, by the way, rather than dementia with Lewy body disease, because a number of the patients I see are not demented in the typical sense, as it were, at least when they start off with us. Not that we cause dementia later, I quickly add, in case that's inferred. A few examples, and there are lots of these, but give you a few. It could be secondary causes, where it's very clear to link them up with amyloidosis, with a very rare condition, which we're very fortunate to have a brother and sister. It could happen to any of us if you've got a high spinal cord injury. As we talk, the incidence in the world of diabetes mellitus goes up, even though a small proportion have got autonomic problems. Because they're so large, a small proportion is an enormous number. Mainly type 1, but increasingly type 2. And as we've recently published, especially those with type 2 who undergo bariatric surgical procedures. Of course, iatrogenic, and this is the one I briefly talked about, increasingly immune-mediated autonomic neuropathy, which, of course, is the most reversible of all of these, as it were. Now, I'm not going to talk about treatment, but just to mention one or two things, because many people say, okay, so what, you've diagnosed this, what are you going to do about these patients? You can't reverse the nerve failure, you can't be doing anything to help them. There's an awful lot which could be done for them, and this is why it's important to know what the mechanisms are, because our patients are increasingly demanding these days, and quite rightly so, that they know why we're doing the things we advocate, as it were. And just very briefly, there could be non-pharmacological measures and pharmacological measures. And I'm going to just give you one example, which a few years ago people didn't believe that 2 glasses of water, about 500 ml, could be very helpful in reversing the most refractory orthostatic hypotension. I'm afraid I didn't believe it myself. I was sent the paper to review, and I thought maybe Nashville water contains something, a pressor agent. But we reproduced this over the years with Thames water, which is pretty safe, I believe. I'm an example of that still alive, as it were. So things such as these can be very important, particularly even in the NHS in the UK, which, as you might have read, is suffering from cash shortages, as it were, so something which is as cheap as that. But the problem being, you can't have your disabled patients carry large cans of water, you see. And this caught my eye, you see. And, you know, being in one of my institutions is known for its engineering skills, so we're still working on small Schweppes-like cans of dehydrated water for people to carry around. Drugs, as I said, the number of them, but just to mention, there could be now increasingly various packages, if I might call that, of autonomic immunotherapy. And I'm just going to mention this one drug here, which has been around and is now licensed, been licensed in Japan and also in the States, not in Europe, sadly so as yet, which is a replacement. So just as in thyroid disease, with hypothyroidism, you give replacement thyroxine and you're pretty well back to normal, as it were, you could do this with LDOPs, and I'll show you why. Now, the reason is if you're deficient in noradrenaline, you use these other agents. You're going to say, why don't you give them noradrenaline? But unfortunately, it's chewed up in the gut. So you've got to give it intravenously, which isn't good news at all. Now, LDOPs, in a way, is very similar to levodopa. So that's the precursor drug. It's absorbed, it's acted upon by dopa decarboxylase, and it's converted into dopamine. This is the same with LDOPs, which is very similar in structure to noradrenaline, and I haven't shown you that because of time. And it's also acted upon by dopa decarboxylase, and in fact, this is about 3 decades ago in the 2 patients with a very rare disorder. We used this drug, and were fortunately, both surprised, and fortunately for them and us, that it acted. 3 decades later, they're still on this drug because it is converted, if I can use the next, into noradrenaline. So all you do is replace these carboxyl groups and you get the noradrenaline structure there. And it can be remarkable as a replacement drug using the drug given orally, as it were. You're going to say, well, the blood pressure goes up, as we know. Does it really matter? And I'm just going to show you the preliminary studies in patients with Parkinson's disease and falls. When you use the placebo drug, you find that there are a large number of falls. Part of these could be the motor aspects, by the way. When you use the drug, you more or less halve the number. So quite a substantial effect in terms of its efficacy in preventing these problems. Now, I'm going to now complete this with the intermittent ones. And of course, this is of, I think, relevance, particularly, even more relevance to epilepsy, possibly, you see. There are 3 types of autonomic mediated syncope, broadly. One is situational, the other is vasovagal, and the third, which occurs mainly in the elderly, it appears, is carotid sinus hypersensitivity. Situational, it can occur in a number of situations. I'm afraid this is slightly out of date, by the way, this slide, because this was linked up with Brexit, which occurred, as you know, in June this year. If any of you have any other updated slides, maybe there's a trumpet slide or whatever it is, you see. But this can happen to anyone, you know, there's mid-duration syncope, weightlifters, a whole range of these things. The most common is vasovagal, which is one of the subtypes of autonomic mediated syncope. And this is an example. This is a patient who's on a tilt table and everything is fine until, and we go back to Professor Berkovich now, in terms of a needle to get some blood for noradrenaline and adrenaline. As you can see, down goes the blood pressure, down goes the heart rate. And this is a typical mixed form. A vasodepressor, because the blood pressure falls as the sympathetic nerves withdraw the activity, and the heart rate falls because the vagus, for reasons unknown to us, becomes overactive. And you can quite see that if you did not have the technology, we used to miss this in the past, and I'll tell you why. It was easy to pick this up, with a normal blood pressure machine in orthostatic hypertension because it remains low for a long period. Here, it's so rapid, if you don't have the modern technological machines which can do advances which can do this, you could miss this quite easily, or consider that it could be something else. These are the types of typical autonomic mediated syncope. This is the vasodepressor predominantly, and here's the heart rate falling, but not a great deal. And again, it's important to pick this up, because some people say, what's all the fuss about? Why do you want to investigate them? This has been going on from Victorian times, if not from before. And, patients have survived. But it's important to get it right. And as pointed out earlier, it has great implications in terms of what they should do, driving, occupation, and so on. This is the one, in fact, which I know it accounts only for about 5 or 10% of the patients that we see. But here's the blood pressure falling, but that's because they've gone into cardiac arrest for about 20 seconds or longer, depending upon the situation. That's the cardio-inhibitory form. Very important, because they should go pretty well straight to our cardiological colleagues and have a cardiac pacemaker put in. Now, I haven't given you examples where it's so important to record these, because we do have a number of cases of loosely called pseudosyncope, functional syncope, whatever it might be. They aren't actually autonomic mediated, because we know that there are no changes in blood pressure, no changes in heart rate, so there could be a psychological aspect which is accounting for this. And this is, I don't know whether it's increasing because of the referrals to us, but it's now becoming far more recognized. I now turn to the last of the aspects on this talk, and that's another one of the intermittent ones, which is very much a new millennium disorder, by the way. And this is the postural tachycardia syndrome, also known as POTS. By the way, it used to be called postural orthostatic tachycardia syndrome, which is really over-egging it, as one would say. And so postural, it flows very well off the tongue, I think, POTS, but with a small o. That's the normal one, hardly any change in blood pressure and heart rate. That's a patient with POTS. The blood pressure is not falling. It may be normal, it may be low, as in this case, or sometimes even high. But look at the heart rate. It's shooting up when they're upright. Hence posture and tachycardia. So that's the typical, and you can see this very clearly, by the way, also on the non-invasive. I didn't talk about another aspect of testing them in the home using machines which are called blood pressure, heart rate, and continuous heart rate with the autonomic protocol. That's a normal one, as you can see, the heart rate lower at night. That's a POTS patient. That's at night, not much change, but look at these spikes in the day, linked up with posture and various other components. I used to call this the Manhattan skyline picture before, and I don't know whether I should be proud of it or the other way around. London, unfortunately, where maybe I've given my views away, has been catching up. It's now the London skyline with the number of skyscrapers we have. What are the characteristics? They are often, but not necessarily, women, and usually on the youngish side, postural dizziness, but also with exertion and after certain foods and alcohol. Palpitations, about a third of them faint. I haven't put in here, because that's active research, on various other seizure-like disorders and motor disorders which they have, and we're not quite sure, is it linked to the condition or is it, partly psychological. I noted some years ago, and I didn't change this, that they were disproportionately disabled compared to our other patients, and there's usually very little to find clinically in these patients, other than the heart rate rose by over 30, or over 120 when they were upright, but without orthostatic hypotension, I quickly add. Now, coming back to this disproportionately disabled, this is a nursing sister in the north of England, and she's allowed me to use this. We'd followed her for many years because she had a tachycardia. We investigated her to the hilt. We couldn't find anything. And she was, very much for research, and she said, I'm going to come to your clinic every year if you don't mind. And I said, great, because she said, I suspect at some stage you'll find out why I've got this. And I said, possibly, but... And I saw, and some years ago she came up at the start of the millennium, and she said, did I know that she was a very good ballerina? She was in her late 40s. And I said, no. I said, it's not my typical neurological, in my repertoire of neurological or other questions that I ask. And she said, yes. And she said, let me give you some examples, and that's that. And I was impressed. Maybe none of you are. And then she said, well, I can do that. And I can do that too. And then the penny dropped that she had something which is known as the joint hypermobility syndrome, which is one component of a connective tissue deficit disorder known as Ehlers-Danlos 3, which is thought to be the benign one. And of course, you can test yourself quite easily. For those of you who wish to do that, you can try and oppose. I can't. There's daylight, if there is daylight here, between my thumb and my forearm. But if you can, that's one of the features which leads you to this, you see. Now, I quickly add, and this is important, that if you diagnose joint hypermobility syndrome, EDS3, it doesn't necessarily mean that you're doomed to getting POTS. Why a proportion of them get POTS, we do not know still. It's the $64 million or whatever it is, the 64 crore question, as it were, you see. What is important is, of course, that patients and the families, because there's an inherited component to this, are told that they can be perfectly normal. In fact, a large number of these, as you see if you're watching gymnastics and the Olympics, if you're tennis fans, very likely, my colleagues who are experts on this tell me that Roger Federer's got it. And I think he's Michael Phelps, the swimmer, has very likely got it too. So you can be not just doing very well, it could be advantageous in terms of your sport, as it were. And by the way, it may be of some relevance to Roger Federer, because while he was bathing his twin girls, I think he's got two sets, he had a problem with his ligament, I'm told, and this is why he was out for quite a long time before he won. Sorry, we're going back to Melbourne. He won the Melbourne Grand Slam, didn't he, or the Melbourne tennis. So EDS3, so keep that in mind. It doesn't necessarily mean, and I think, Krish, I think you've seen the slides when we visited you, the Bharatanatyam dancers, they virtually all have EDS3, but they're far fitter than a number of us put together, I think. Management, again, I'm going to say very little about it other than and I think I'm going to address this more tomorrow with integrated neurocare because this is so important, is that in addition to the treatment of POTS and the autonomic aspects, it's very important to treat the associated disorder or condition. And again, I can't labor this further, but just to in fact summarize and say that POTS is a very valuable at times autonomic biomarker. There can be multi-system involvement, there can be and multiple morbidities, and of course a holistic management approach is very important. That, by the way, needs updating. This was published about 5 years ago, and things have changed enormously because we now realize that these patients have got gut, or some of them, have got gut problems, bladder problems, what's known as the mast cell activation disorder syndrome, so all sorts of things which need to be factored in. So, ladies and gentlemen, thank you very much for listening to the odd man out, as it were, the non-epileptic person, but I hope this indicates that there is an overlap at times, and it's important to consider autonomic disorders and to investigate them appropriately. Thank you very much.
Thank you. Thank you, Christopher, for bringing out a very important area which needs to be differentiated from epilepsy, and especially the new millennium disease you have brought into the picture, which is extremely important for us to know. Thank you.